welcome everyone to our live webinar. AREP is a small group of motivated radiologists from Asia, Iraq, and the USA. We do radiology broadcasts twice a month on the first and the third Sundays in multiple subspecialties. Our first 2 months, which is January and February, is neuroradiology. At the end of this webinar, there will be a survey to improve the quality of our broadcast. Please help us to answer the survey questions and to get your certification of attendance. Also, we will have a quiz question at the end of the webinar. 2 people who get 2 right answers in January will get a little gift from us. Next, if you have trouble about the broadcasting, please contact our Thailand IT team. The contact detail is in the flyer. And we would like to thank our manpower, especially Thailand IT team, Indonesia Sailing Committee team, and Dr. Sangye from Bhutan, who did a great job of our member list. And our next Sunday at the same time, please join us for imaging of cellular and paracellular tumor by Dr. Zamola from University of North Carolina or UNC. And now I would like to pass on this task to Dr. Gao Ampan, who is our moderator today. Dr. Gao Ampan, please.
Thank you, Dr. Nat. Good evening from Thailand, everyone, and thank you for joining us today. My name is Uttarat Kaewampon, a neuroradiology staff from Sirat Hospital, Bangkok, Thailand, and I'm honored to serve as a moderator today. It's now my great pleasure to introduce Professor Bandit Tantiwongkosi from University of Texas Health, San Antonio, USA. Professor Bandit is a clinical professor of radiology and otolaryngology and has a specific interest in head and neck and ophthalmology imaging. He also tried to help radiology education in developing countries, in particular the Southeast Asia, by joining a few outreach programs and teaching them remotely outside of using online platforms like today. And of course, today he has again an interesting lecture titled Imaging of the Laryngeal and Hypopharyngeal Cancer. Without further ado, please join me in welcoming Professor Bandit Tantiwongkosi.
Thank you so much for the nice invitation and the introduction. I'm very honored to be here today. This is my second time joining the AREP for the lecture. And I will try to go as, appropriately paced as possible. It's a little complex, but I'll do my best. I'm gonna stop the video so you can focus on this. Close that. So today, we're gonna focus on the anatomy of the larynx and hypopharynx. I'm gonna show you a lot of diagrams of the CT and the MRI, staging of the cancers, and showing you some post-treatment changes. So let's start from compartmentalize the neck soft tissue. So this is a sagittal CT. You may need to know a few landmarks. So this one is the hyoid bone. You draw a line here, the hard palate, another line, the cricoid cartilage at the inferior margin, another line at the posterior margin of the cricoid, and a line connecting the posterior aspect of the hard palate and the hyoid bone. Now we can, put things together. This is a nasopharynx, oropharynx, oral cavity, larynx, hypopharynx, trachea, and esophagus. So this is a very rough estimate of the boundaries of the neck compartment. So today we will focus on the larynx and hypopharyngeal cancers. So the larynx is made from a cartilage framework. The major one is the thyroid cartilage, look like a shield, right here. Then we have a cricoid cartilage, look like a ring. And this is the back of the ring facing anteriorly and the head of the ring facing posteriorly. And a really nice and beautiful triangular shaped arytenoid cartilage sitting on top of the superior margin of the head of this cricoid cartilage, and we have a very nice and beautiful pear-shaped epiglottis at the anterior aspect. Then with a very cute bone here, this is the hyoid cartilage here, sitting on top. This is actually not a part of the laryngeal framework per se, but it is very important because it keeps holding the larynx to the superior aspect of the neck. There are a few membranes that you may not see on CT or MRI. So we have a thyrohyoid membrane right here, and the anterior part of the cricothyroid membrane. If you look at the back, again, there is going to be a cricothyroid membrane and erythrothyroid membrane at the back of the cartilage. So on sagittal view, thyroid cartilage, cricoid cartilage, erythroid sit on top of the cricoid, and the true vocal fold is, if you use the anterior process of the erythroid cartilage, this is a good landmark of the true vocal fold on sagittal view. Immediately above that is the laryngeal ventricle. And the epiglottis arising from here go up at the level of the oropharynx even, and there is a little fat right here. This is a pre-epiglottic fat. This is the area epiglottic fold. Inferior to the true vocal fold is the subglottis. And on the coronal view again, if you look at the glottis, superior to that is the laryngeal ventricle, false vocal fold, area epiglottic fold. Inferior to that is the subglottis. So I apologize, the diagram is incorrect. It should stop at the level of the inferior margin of the cricoid right here. And there is a little line here, you may not see it on any type of imaging, even CT or MRI, but the expected location of a fascia named conus elasticus right here, bridging between the true vocal fold to the inner margin of the cricoid cartilage. If the tumor arising medial to the conus elasticus, it can extend inferiorly and erode the inferior margin of the cricoid. But if the tumor is superior or lateral to that, it's kind of this conus elasticus kind of keep preventing tumor going downwards. But anyway, aggressive tumor can go anywhere it wants. Okay. So on sagittal view, again, when you look at the larynx, the first stop for me is look at the cartilage first. So you know where things are. This is the thyroid cartilage and the back of the cricoid cartilage. Then you see the erythroid cartilage, the anterior process or vocal process of the erythroid cartilage. And then this is very nice and beautiful true vocal fold. Superior to that is the laryngeal ventricle. Then you have the epiglottis right here. You have base of tongue, you have molecular and anterior pre-epiglottic fat right here. And you even see the expected location of the thyrohyoid membrane and the cricoid right here. So this is thyrocricoid membrane expected location. On axial view at the level of the true vocal fold, how do I know? This is a true vocal fold because I see the erythroid cartilage, the anterior process, and this density contains 3 structures, but the whole thing is called the true vocal fold. From lateral to medial, you don't need to separate the 3 structures. You just say true vocal and you are good. This is thyroarytenoid muscle, at the lateral aspect. Then you have vocalis muscle, and the very medial aspect is the vocal ligament. But the 3 things are called true vocal folds. Then again, this is a cricoid cartilage, and posterior to that is the retrocricoid hypopharynx. One thing I wanted to point it out to you, there's a little space right here. This is a thyroarytenoid joint or thyroarytenoid space. There's a little membrane. It's usually a few millimeters. If it is wide, then you have to think about there is anything such as a tumor going from the back, from the front to the back right here. So make sure that you look at this space carefully. If you cut at the supraglottic larynx, you'll see this is area epiglottic fold. This is the hyoid cartilage, pre-epiglottic fat, paraglottic fat. This is the epiglottis. Preform sinus is a part of the hypopharynx, not the larynx per se. Then you have thyroid cartilage and strap muscles. at the level of the subglottis right here. If you do the axial view, again, you will see the thyroid cartilage and cricoid cartilage. Again, make sure that you look at the thyrocricoid space. Is usually maybe up to 5 millimeter, but not like a centimeter, and make sure that it is widened. It may be due to a mass that's sitting next to it. Okay, coronal view, very easy. We have the hyoid thyroid cartilage, and you may see that this, ossification is not homogeneous, and this is always difficult. Like, is there a tumor in there, but when it's not homogeneously ossified or calcified, this is a normal variant. Then inferior to that is a cricoid cartilage. Then you may see this is expected location of the thyrocricoid space. You can see that it's not that wide and it's quite, equal. Then you look at the true vocal fold. So prior to that is the laryngeal ventricle. This is the false vocal fold right here. Then this is the area epiglottic fold. And you can see the space here. This is expected location of the thyrohyoid membrane. And you can see that medial to that is fat, You will see a soft tissue tumor protruding violating this fat. And then you need to, describe that and put that in your report. And endoscopic correlation and thyroid cartilage, arytenoid cartilage, and this is true vocal fold that happened to close. And this is true vocal fold and this anterior commissure right here. So, well, all they see on endoscopy is mucosal lesion. So to me, ENT doc is a mucosal doctor, but we see more than that. We see more of the submucosal, look, extension of the tumor and cartilage and deep destruction. So as a radiologist, I consider myself a submucosal doctor. Another correlation, this is a tumor involving two sides of the true vocal fold is right here. They see this very well on endoscopy. So they actually want us to say how deep these things go. And I'm going to show to you, from now on, how deep things are. So 60% of the laryngeal cancer involve the true vocal fold or the glottic cancer. Patients present early due to airway obstruction and change of voice. 35% involve the supraglottis, and typically the patient show up with dysphagia, and it's very rich in lymphatic system, so patient may present late or higher stage, similar to subglottic cancer, but this is quite rare, but has poorer prognosis. So, everyone talking about HPV correlation, 25% of the laryngeal and oropharyngeal cancer are actually P16 positive, but we almost routinely test P16 status in almost head and neck cancer patients. And then we found that 25% of them, of the laryngeal and oropharyngeal cancer are HPV positive. But how do we interpret that? So they say, for the literature, there's a poor correlation between HPV and P16 status in a laryngeal cancer on survival. So this poor correlation, maybe that's not that matter for laryngeal cancer, but there is a strong correlation between HPV and P16 status in hypopharyngeal cancer on survival. But anyway, at this moment in time, we do not use P16 status to stage the patient, so it does not matter in terms of staging. So start from the true vocal fold of glottic cancer. T1 is a small lesion. Actually, it's a lesion that involves only the true vocal fold. It may or may not involve anterior or posterior commissure. Involvement of the anterior or posterior commissure does not affect the stage, but it may represent poor prognosis because of the chance of the tumor recurrence. To qualify for T1, the cord had to move normally. If a small lesion involved in one side of the cord, it's called T1A. Both vocal folds is T1B. For T2, the tumor involved two subsides. So the tumor may go up and involve supraglottis and may come down to involve the subglottis, or the cord may move. There is an impairment of the cord mobility. For T3, regardless of the size of the tumor, If the cord fixed, it's immediately staged at T3, or when the tumor large enough or deep enough to involve the paraglottic space or inner cortex of the thyroid cartilage. We will go over this diagram in depth in a little bit. But if it is involved, the inner and outer cortex of the thyroid cartilage, this will be a T4A, and if it's involved the tissue above, outside the larynx, such as it go inferiorly to involve the trachea, going down to involve the cricoid cartilage, the extrinsic muscle of the tongue, the step muscle is very common. The thyroid or esophagus is called as a T4A. For T4B, that means it go way beyond, to the prevertebral soft tissue or space, in case internal carotid or carotid arteries, and then it may go even more inferior to the mediastinum. For the supraglottic cancer, the T4A and T4B are quite similar. But for T1, it involves only one subsite of the supraglottis and the cord moves normal. For T2 of the supraglottic cancer, it involves more than one subsite. For T3, the cord is fixed and it may involve the pre or paraglottic fat. If it involves the thyroid cartilage, it's only the inner cortex. So the keyword for this is you need to know the cord mobility. If there is a small tumor, limited tumor, but the cord is fixed, it will be upstage to T3. So please look at the medical record or call the ENT surgeons asking about what is the cord status, except when they, the patient's, brand new in the ER, no one knows what happened. But anyway, the final stage, clinical stage, they need to include the function of the vocal fold or the vocal cord. For the subglottic region, T4A and T4B are quite similar. T1 involve only subglottis, T2 involving the true vocal fold with hair, with impaired mobility, T3 again, the cord fixation. So again, you need to know the mobility of the true vocal fold movement. Okay, so as I tell you, the glottis, supraglottis, subglottis, the size does not matter, but the extension and the status of the cord movement are far more important. This is very different from hypopharynx. Hypopharynx, the size, less than 2 to 4, greater than 4 are T1, T2, and T3. Quite similar to the oral cavity and oropharynx. The larynx, there's no measurement. You make, of course, you need to make a measurement of the size of the tumor, but it does not really affect the staging in the larynx. It affects staging of the oral cavity, the oropharynx, and hypopharynx, for example. So Andrea, commercial involvement does not change the stage, but the patient may have more chance of recurrences involved in entry of posterior commissure. If it's thicker than 2 millimeters, we need to be careful and look at it closely. So treatment is different for low stage and high stage. Low stage means T1, T2, T3, and high stage is T4 and above. For T1 and T2, the patient may be treated by one modality. The patient had an option. They want to do radio surgery or they want to do surgery, like open surgery or endoscopic surgery. So they can pick one, radiation versus surgery. For T3, they can pick radiation or surgery, but at the end they need to have chemotherapy. And as you know, chemo had a lot of side effects, drug reactions. So T1 versus T3 is different. Small lesion could be T1 if the cord move normally. Small lesion that impair, or if it fixes the vocal cord, it will be T3, and that means the patient needs chemo. For T4, the patient needs both surgery, chemotherapy, and radiation. For stage 3 and stage 4, tumor, but the cord remain moving or not involve any abnormality of the spinal of the cord through vocal fold movement. The patient may have an option of having concurrent chemoradiation, but if the thyroid cartilage, arytenoid cartilage, every any of the cartilage framework, or when you think the larynx cartilage framework is destroyed, that means that's not an option. The patient will be not a good candidate for organ preservation therapy. So there are two ways for laryngeal surgery. One is partial laryngectomy, and the other one is a total laryngectomy. Partial laryngectomy is a type of organ preservation. It's good for glottic and supraglottic tumor when they are small. They have an option to do endoscopic versus open surgery. They may perform only, cordectomy or vertical laryngectomy or hemilaryngectomy or any variant of that, but not total laryngectomy. So the surgeon may decide to take the whole larynx out if the tumor is large, the node is positive, particularly the supraglottic and glottic tumor. The subglottic tumor, typically they don't want to do just partial laryngectomy. They prefer doing total laryngectomy for any subglottic tumor. When the cartilage is destroyed or extensive extension of the tumor, the whole cartilage has to be removed. I mean the whole larynx. So let's look at an example. This is a tumor so the right side is normal. This is a true vocal fold because it's at the arytenoid cartilage. So the cord moves fine. So this stage as a T1. If the vocal cord does not move at all, it's going to be T3. If it moved but not perfectly, it will be T2. So one picture, it can be any 1, 2, or 3. You need to know the cord mobility. There's a little line here, this is kind of new to me as well. So if you look at this tumor, if the tumor stay anterior to this line, you draw a line at the arytenoid cartilage going into the inner cortex of the thyroid cartilage. So if the tumor remains anterior to that, they believe this is better than violation at the posterior aspect. This is the tumor right here on the right side, but there is decreased cord mobility. And this is a good time to call T2 lesion. And it involves two subsites, true vocal fold and subglottis. This is a T3 for paraglottic involvement. This is a supraglottic tumor on the right side. The left side, this is a paraglottic fat, that's normal. Pre-epiglottic fat, normal. And on the right side, you see involvement of the paraglottic fat, normal fat, paraglottic fat, abnormal involvement of the paraglottic fat by the tumor. So this is T3. T3 mean what? Mean chemotherapy is added at the end of the treatment. And this is the epiglottic fat. The fat is supposed to look like this. But this supraglottic tumor go anteriorly. So this is T3. T3 means chemotherapy is added at the end of the treatment. So there's a term transglottic cancer. Transglottic means vertical extension of the tumor. So this is the expected location of the true vocal fold. If the tumor crosses the laryngeal ventricle, is called transglottic. Meaning what? If this supraglottic tumor crosses the laryngeal ventricle, to involve the true vocal fold, that means it's a transglottic, but in the sense of craniocaudal dimension. There are 8 patterns of extralaryngeal spread to make the tumor T4. I will go through the whole list one by one. So you don't need to remember all of this, but if you look at it, you will be, it's gonna make sense. So the most common one is the thyroid cartilage penetration. This is the most common T4 you're gonna see. There is a large tumor here, transglottic carcinoma. This is the thyroid cartilage, and a little cut below that, the whole thyroid cartilages on left and right side are destroyed, and there are tumors all over the place. So this is a T4, and this is the most common pattern of T4. We talked about it before. This is the thyroid cartilage. There is inner and there is another outer cortex of the thyroid cartilage. If the tumor invade only the inner cortex, and just approach the outer cortex, may involve the outer cortex a little bit, but not into the strap muscle. This is called invasion, and penetration is called as a T3. If the anterior and posterior cortex are involved and the tumor extend into the strap muscles, that counts as a T4A. Example on the right here, this is invasion of the inner cortex only. This is a T3. This kind of approach the outer cortex, but nothing going, outside. This considered penetration for T3, and this one in the strap muscle. So this is a T4A. Another common one is the cricoid cartilage, the thyroid cartilage involvement, and this is the cricoid cartilage. The ring we talk about is all involved. It is also another common one when the tumor penetrating inferiorly to involve the cricoid ring and then decided to go outside the strap muscles. So this is very common. You don't need me to point it out to you. But now this case you need to learn, but this may be new to you. So again, when I look at the larynx, I kind of oriented myself by looking at the cartilage framework first. Number one, I see the hyoid cartilage right here. I see thyroid cartilage right here. I see tracheostomy, and I see a huge mass. This mass going more to the right, there is a fat right here, which is normal. The hyoid and thyroid cartilage, that is a membrane, and medial to the membrane is fat. So the tumor stops right here. But on the right, the tumor go laterally through the thyroid membrane. This is the expected location of it. And you can see maybe a little part of it is widened, normal, not normal. And then your eyes kind of go to that. And this is the tumor penetrating through the thyroid membrane into the extralaryngeal space. And if I do the axial view right here, you may see the supraglottic tumor through the expected location of the thyroid membrane. When you look at that, instead of T3, this is a T4A. The patient may need laryngectomy. So another way is anterior extension, into the thyroid notch. Where is the thyroid notch? Very simple. Go up to the superior margin of the thyroid cartilage. The most superior aspect of it is the thyroid notch. This tumor, supraglottic tumor, go above the superior margin of the thyroid cartilage. This is the thyroid notch, making it as a T4. As I told you before, the thyrocricoid space is a few millimeters. Now this is the thyroid cartilage, and this is a cricoid or arytenoid. Then there is a huge mass protruding through this little space. You can see that this is very widened, and there is no direct extension into the cartilages themselves, but the tumor widened the space and make its way outside the larynx, making it a T4 lesion. So the supraglottic tumor that go above and involve the base of tongue, make sure that you look at everything, supraglottic tumor, and guess what? This is the base of tongue, glottis, and guess what? There is another tumor right here, make it as an advanced stage. If the lesion arising from the true vocal fold, this make it as a T4A. If a supraglottic tumor that involve the base of tongue is called as a T2. So make sure that you look all the way. To me, I look all the way from the skull base, but make sure that you don't stop your eyes just right here. Go a little above and you may see something that you don't expect. So thyroid membrane, again, thyroid cartilage, cricoid cartilage, thyrocricoid membrane is right there. And this, cricoid cartilage right here, there is invasion through the thyroid cartilage itself and through the thyrocricoid membrane into the strap muscle. This is just for fun, involvement of the conus elasticus. We don't actually see this, but I mean, the membrane itself, but you know that the conus elasticus extends from the true vocal folds to the inner margin of the cricoid cartilage, and this tumor involved and penetrating through that. And this is a supraglottic tumor that go all the way back, and involve prevertebral soft tissue. So this is T4B. A large tumor, this is whole thyroid cartilage involvement. So we actually don't need MRI for this. That is the role of MRI and CT. MRI tend to overestimate the involvement of the cartilage, and it may lead to overtreatment. CT typically underestimate the involvement of the cartilage and may lead to inadequate treatment. But if the MRI is completely negative, it helps exclude the cartilage invasion. It has very high negative predictive value. There is tumor sitting right here. Is there any involvement of the cartilage? We don't know. So I bring the patient back and perform MRI. Guess what? I see inner and outer cartilage very well. So this is an example of a negative MRI. And on surgery, the patient does not have any thyroid cartilage involvement. So this is a good example of a true thyroid cartilage involvement, true positive of MRI. This is T1, T2, T1 hypointense, T2 hyperintense, and the tumor is enhancing. And when you look at the cartilage right here on T1, it's kind of dark. Is that real? Is that inflammation or is it a tumor? But when you follow on T2, the cartilage has similar signal as the tumor and enhance at the similar level. So if the cartilage signal is equal to the tumor signal, it is a true involvement. This is example when the cartilage is so bright as compared to the tumor itself on T2, and when the cartilage enhance more than the tumor itself. So this is inflammation of the cartilage on MRI. This is a false positive. So make sure that you compare T2 signal of the cartilage to the tumor itself. Okay, we went through that already. So the retropharyngeal fat kind of help in terms of determination of prevertebral soft tissue involvement. So this is a normal fat right here, prevertebral or retropharyngeal fat. If this fat is intact, it's kind of help that telling you that there is no tumor from the front that involves the back. So this is a good example of the tumor on the right, and you see the fat signal is intact. So this is not a T4B though. It is just a lower grade tumor, T4A. But this one is a different case. The tumor involves the fat on the right. It's supposed to look like this. So it is T4B for this one. However, I'm going to show you another case that the tumor is large and there's no fat left at all. But on pan endoscopy, the surgeon was able to lift this tumor up, anteriorly lift it away from the prevertebral soft tissue. So in fact, this is a good example of a false positive MRI. Even the fat is gone. So to make sure that you understand that the gold standard of prevertebral soft tissue involvement is actually not MRI, not CT, but pan endoscopy with intraoperative findings. So let's look at some post-operative changes. This is a large tumor, a T4A lesion, right here. So if you could imagine, you just take this out, and perform total laryngectomy. Basically, the tumor was removed. The surgeon separate the airways from the neopharynx. So the patients breathe through this, trachea and then swallow or eat through this neopharynx. But the chance of being aspirate is very, very low. And there is a little thing here, this is a foreign body. This is intentional. It's called TEP or tracheoesophageal puncture. It helped the patient in terms of vocalization. Pre-treatment, before total laryngectomy. Basically, you just scoop out the larynx, and the patient's typically looking like this. Yeah, this is the same patient with 3D rendering. So after total laryngectomy, the esophagus or neopharynx is typically dilated because the larynx was removed. So there's nothing to prevent the esophagus. So it's dilated and look quite like trachea. And the thyroid, become more oval or rounded and look like an enhancing lymph node. So I want to make sure that you understand that expected imaging finding of the total laryngectomy look like this. So make sure that you train your eyes and look at the recurrent tumor. It is typically around the total laryngectomy margin. I use the clip to help me. Typically next to the clip, the tumor like to recur, but this one is very difficult, but very obvious on PET CT. Yeah. So if you're not sure, use PET CT. If you don't have PET CT, look around the clips. But PET CT also have false positive. This one, the tumor was removed on the left, and then the right side is compensatory hypertrophied and worked too much. So it's become hot, but this is expected. This is not a tumor. This one, the patient got Teflon injection and it's hot and look like tumor. Make sure that you go back and look at the source images. The picture on the left side, this is a subglottic tumor, pre and post, and the patient got treated, and you may see that there's a new soft tissue lesion around here. And when I look at this, could this be a recurrent tumor or could this be secretion, But when I see that it's a new erosion of the cricoid cartilage, so this is not just secretion, this is a recurrent tumor. Talking about chondroradial necrosis, you may say that this is a normal right thyroid cartilage. This is the abnormal left thyroid cartilage, and the adjacent soft tissue become necrotic. So this is thyroid chondroradial necrosis, and this is the cricoid chondroradial necrosis, and this is the hyoid part that become necrotic. So having gas in the cartilage or bone is not normal. And it's a good early sign of chondroradial necrosis, So it's serious complication. You try to preserve the larynx, but finally the larynx necrotic is solved. There's something called Chandler, grade 1, 2, 3, and 4. Grade 1 is mild. Grade 4 is complicated or severe. And grade 1, you may treat symptomatically, and grade 4, the patient may end up, having tracheostomy or laryngectomy. Gonna pass that. And the thyroid may become necrotic. This is pre-treatment. Normal thyroid on the right. And this is air and necrotic right thyroid cartilage after 1 year. So in summary for the larynx, we went over the anatomy of the supraglottis, glottis, and subglottis. We talk about tumor extension dictates the staging of the treatment. Size does not change or dictate the staging in the larynx, but it changed the staging of the hypopharynx that I'm going to talk about in a minute. For early stage, the patient has an option to go through radiation or surgery, which has similar outcome. For the late stage, but the cartilage or the larynx function is still okay. The patient may have concurrent chemoradiation, but if the cartilage or the cord does not function anymore, so the patient needs to have total laryngectomy. CT, MRI, and I want to add PET CT, and physical findings are complementary in evaluation of tumor staging. Extralaryngeal invasion, there are many patterns, at least there are 8 patterns under my observation. You need to look from top to bottom, from front to back, right to left, make sure that everything is intact before making a call. And the gold standard for pre-vertebral soft tissue evaluation is the endoscopic exam. Okay. Let's go over the hypopharynx. Okay, so I went through that. The hypopharynx is this area. This is very small area of human body, it's just behind the cricoid cartilage. So another way to look at that is looking at the Barren swelling. I'm not a GI person, but I love looking at this picture. So we have a base of tongue right here. We have a vernacular. Then we have piriform sinus. You know that piriform sinus is a part of the hypopharynx. This patient having, everybody know about LMA, right? The laryngeal mass airways. So the patient got the laryngeal mass, put it in, and the tip of the laryngeal mass separating the retrocricoid space or the hypopharynx from the prevertebral soft tissue. So piriform sinus is one subsite, retrocricoid mucosa is another subsite, and we have prevertebral mucosa as the third subsite. Basically, the hypopharynx. If someone asks you where is the hypopharynx, your job is to look at the cricoid cartilage and point to the back of it. So that is your job. That's very easy right here. Oh, you may use C7 though. Above C7, this little area is called hypopharynx, and below that is the esophagus. You may use that as well. So this is, again, if you remove the laryngeal mass out, you may see the retrocricoid and prevertebral posterior hypopharyngeal wall. So this part is a part of the hypopharynx. So on axial view, retrocricoid and prevertebral mucosa, this area is the hypopharynx. It's very small location of the human body. This patient happened to swallow a lot of air. I actually don't ask the patient to do this, but this is a very beautiful, that is a supraglottis cyst right here. You may see the very large piriform sinus. This is an unusual case. I love it. And then you may see the cricoid cartilage, retrocricoid hypopharyngeal mucosa, and this is prevertebral mucosa of the hypopharynx. Again, I show you, the same pictures many times. You see the vallicular and piriform sinuses. This is the same case. The piriform sinus is dilated so bad. This is very beautiful, and the tip, of the piriform sinus is actually at the level of the arytenoid cartilage. So you can use the cricoid arytenoid cartilage to find a true vocal fold, and you can use the same structure to find the tip of the piriform sinus. But the majority of the time, the piriform sinus is not this dilated this much. This is an exceptional case. Hypopharyngeal cancer is quite rare. It's only 4% of all head and neck cancers. The majority of them are squamous cell carcinoma, and it has the poor prognosis of the head and neck squamous cell carcinoma. 5-year survival rate overall is about 30%. Again, it's associated with alcohol consumptions and tobacco smoking. It may associate with Plummer-Vinson syndrome. So this may be in your written board. Male more than female, about 3:1 ratio. Typically, the patient presents very late, stage 3 and 4, because of the lymphatic drainage in the hypopharynx is very rich. So it's typically metastasized to the lymph node level 2, 3, and 4 at the early stage. And the primary role of the radiologist, again, similar to the laryngeal cancer, is to look for deep invasion. So again, the majority of them involve the piriform sinus, 65%, up to 20% involve prevertebral mucosa, hypopharyngeal space. Post-cricoid, about 20%, and it may relate to the Plummer-Vinson. T1, one subsite, and less than 2 centimeters. Again, now the 2 to 4 greater than 4 come back this, into this hypopharynx, similar to the oral cavity and oropharyngeal cancer. For T2, it involves more than one subsite, for example, from the hypopharynx, and then it involves the supraglottis, for example. It's 2 to 4 centimeter or T3 greater than 4 with fixation of the cord. And this is a little details, but I think this is very detailed. I just study and learn about this. If it's involved the esophageal mucosa, it's called a T3, but if it's involved esophageal muscle, it's a T4. And to be honest with you, I don't think it's our job as a radiologist to differentiate between esophageal mucosa and esophageal muscle. I think this is too much. And I think who make this call is supposed to be the pathologist, right? But if you just say it's involved esophagus and could represent a T4A as the most. So I think you did this job right away correctly. So for T4A, it may involve the thyroid cartilage, hyoid bone, thyroid gland, and central compartment of the neck. So central compartment means scalp muscle and subcutaneous fat. And T4B is pretty much quite like the laryngeal cancer, you know, the carotid and stuff. Okay, let's look at some images. So this is a small T1, less than 2 centimeter, and this is the most common location of it. 65% of the hypopharyngeal cancer are in this area, and this is a T1, less than 2 centimeter, involving one subsite. The vocal cord move fine, so this is a good T1. This is a T2, about 2 to 4 centimeter, so it's called as a T2 lesion. This is T3 lesion when it involves piriform sinus and it starts going down to the retrocricoid. So piriform sinus right here, plus retrocricoid. So there's 2 subsites. Yeah, so that's more than 1 subsite. So that's a T2. The cord move, you know, okay. This is a large tumor in the hypopharynx, in the piriform sinus, but this one it extends at the level of the true vocal folds. So there's more than subsite and it's involved the cord, and the cord fixed will make it as a T3, and the same big tumor is greater than 4. So this is a full view, a very good example of the T3 lesion. This is a T4A lesion again, you know, in the piriform sinus, and now it's go back through this thyrocricoid space involving the posterior aspect. So this is extra laryngeal extension version of the T4A. And of course, if you look at the cartilage, the whole left side, the posterior aspect of the left side of the thyroid cartilage is gone. So the cartilage is already gone. So that's a T4A. And this one involves the prevertebral soft tissue. You know, this is bad. So this make it as a T4B. Yeah, this is retrocricoid and piriform sinus, very extensive, going to the back, involving the prevertebral soft tissue. So pearls and pitfalls of the hypopharyngeal cancer. In fact, laryngeal cancer involving the hypopharynx is more common than primary hypopharyngeal cancer. But since I work in a very busy head and neck cancer service, I see a lot of primary hypopharyngeal cancer myself. So the piriform sinuses can be asymmetric and could be a normal variant. But if the patient show up with, you know, cervical lymphadenopathy and have, you know, risk factors, alcohols, tobaccos, any asymmetry of the hypopharynx or piriform sinus count, you need to report it and have them correlate with the endoscopic findings. The hypopharynx is typically not distended, you know, so it's very difficult sometimes. If it's greater than 1 centimeter thick at the postcricoid soft tissue, you need to be cautious, particularly when it's enhanced and mass-like. So don't hesitate to tell them to go back to do the direct inspection. Again, MRI may be helpful, similar to the laryngeal cancer that I showed you to you before. So in summary, for hypopharyngeal cancer, for hypopharynx, we talk about the 3 subsites of the hypopharynx, including the piriform sinus, retrocricoid, and prevertebral mucosa. We talk about the staging. The size does matter. Less than 2, 2 to 4, and greater than 4 count as T1, T2, and T3. We talk about 1 subsite, greater than 2 subsite, you know, more than 1 subsite and then more than 1 subsite. Then we talk about quad mobility, similar to the laryngeal cancer staging. You need to know the cords, the true vocal cord status. And we talk about adjacent soft tissue and involvement. If the cord is fixed, it's immediately translated into the T3, and T4B is quite similar to the laryngeal cancer. So this is all I have for now. This is my references. Again, I would like to thank for your attention, and then I'm open for a question.
Okay.
Uh-huh.
Thank you so much, Professor Bandit, for your consistently wonderful lecture.
Thank
Now it's
you.
time to move to the Q&A session.
Okay.
Anyone with question can type them into the Q&A box. And now I think we have one question.
Do you use, what is that, ultrasound?
I think ultrasonography routinely. And any significant finding in ultrasonography or other modalities?
Yeah, I think no, we don't use ultrasound for direct visualization of the larynx and the hypopharynx itself. But if the patient show up with lymphadenopathy, we use ultrasound, to analyze the lymph node and perform ultrasound guided biopsy of the lymph node. But I myself never use ultrasound to do this at all. I mean, in terms of the larynx or hypopharynx itself. Well, there's quite a few people asking about the MRI. This is very controversial. To be able to use MRI effectively for hypopharynx and larynx, the patient has to be able to hold still, and you need to use a dedicated coils. Some people use shoulder coils to put at the front of the neck, and or some hospital has dedicated neck coils that would be a better options. But the patient has to be so still, otherwise it's going to be very difficult to image the larynx. Patients with laryngeal cancer typically have pain and have problem with swallowing. So to ask them to breathe slowly is going to be very challenging. And some patients already have trach, and having a trach is not a pleasant thing to have. Yeah, so I no role much for ultrasounds except for lymphadenopathy. Yeah. Any other question?
Thank you, Dr. Bandit, for your very thorough and precise and very clear letter on such a very challenging and
complicated topic. You are very welcome. Yeah.
And I have one question for about the post-treatment imaging.
Yeah.
When we like to assess the response of the tumor to the radiotherapy, and what about what kind of imaging would be the best option to detect the post-radiation changes and recurrence is very challenging. Thank you.
But it is, this is a very good question and very practical. So so the protocol that we use, if it is a very small, it depends on the staging of the tumor. When it's a very small tumor like a T1, T1A, or even T1B, and they perform complete tumor resection, they usually just follow the patient with CT with contrast, and routine endoscopic exam. But if the tumor is very big or later stage, like a T3 and T4, and the patient already undergone chemoradiation, in that case, in the US, we typically performed PET-CT at least, 8 to 12 weeks after last dose of chemotherapy. But if the patient has only surgery without chemo, so if the patient has surgery with chemo, you may shorten the follow-up study with the PET-CT instead of 12 weeks. you may perform PET CT about 6 weeks if there is no radiation, but it's very controversial. But I still suggest them to do at least 2 to 3 months or even 4 months, that would be the best option if the patient has radiation.
Thank you. Thank you so much for the
Welcome.
timely the decision.
Yeah, you're welcome. Good question. Thank you.
Thank you.
Okay, I think we have time for another question. Are there any clues to differentiate between hypopharyngeal and laryngeal cancer when they are like large enough to occupy both areas?
Very, very good. Yeah. Mm-hmm. When they are very large, it is very difficult to know where it starts. There is one clue that I use, So there's one thing that I have not included in my talk, but I think it's critical. If you see a large tumor, this type of tumor arises from the mucosa, correct? So when it's large, it just goes spreading all over the place, and it's very difficult to know where it is. And you can apply that to the oropharynx and nasopharynx. When it's very large, does it come from the oropharynx going up, or the nasopharynx coming down, or is that from the oral cavity going back to the oropharynx, or the oropharynx going front to the oral cavity? Same thing here, but there is one pattern that is really helpful. If there is extensive submucosal extension in the area, it is typically the hypopharynx. The laryngeal cancer, supraglottis cancer, typically spread at the superficial part. Once it arises from the mucosa, it spread along the mucosa to everywhere. But a variant of the tumor that arises from the mucosa and then it go under the surface is typically hypopharynx more often than the large supraglottis. This is not a common manifestation. I have seen less than 10 cases in my career, meaning what? If the tumor is large in that area, they did the scope and the mucosa is abnormal, but not much. But there's a lot of mass underneath the mucosa that's underneath that. And then typically it's a hypopharynx. Yeah, very good question. So what happens if you don't know? If you don't know, same thing, you use the common sense. If I use the center of the lesion. If it is in the supraglottis, I typically say this is a supraglottic tumor. I use the broad term. I think it's the supraglottic transglottic tumor. That means it arises most likely to be the supraglottis, and then it goes south to involve the true cord letter. One thing that I use is clinical of the patient. If the patient come in with chronic hoarseness of voice, not that long, but start with hoarseness of voice. Typically start from glottis and then go up to the glottis. So you have to combine clinical presentation. And as I told you before, glottic tumor come pretty quickly because of the hoarseness of voice and airway obstruction. If the tumor happens to be so large and the patient never come to the hospital yet, it typically starts from the supraglottis. It takes so long to go south and involve the cord, and the patient come in with airway obstruction. That's usually a good clue that it's not coming from a true cord.
Okay, thank you so much, Professor. Okay, one last question. How can we differentiate between tumor invasion to the thyroid cartilage and incomplete ossification of thyroid cartilage itself from CT scan imaging?
Yeah, this is a hard question, but you may do MRI and look at the pattern of enhancement and T2. If not, it's almost like flipping a coin. But if you look at the density of the incomplete ossification, if it's really dense, and it's matched with the density of the tumor, that would be another clue, But a lot of time without MRI, I cannot tell. I just say, you you may need to do MR. Yeah. It's always a question. We always discuss about this in the tumor board, and there's no question. I mean answers. Yeah.
Okay. Now it's
All
time
right.
to move to the quiz session. Okay, and thank you so much.
Oh yeah, you are welcome.
And thank you so much, Professor Bandit, and every attendee who participation in the Q&A session. Okay, let me show the slide for the quiz session. Okay, first of all, let me reintroduce about the reward for those who give the correct answer to the 2 questions in this month quizzes, today quiz and the previous one. You will have a chance to receive this lovely Quizlet. Just wait for our email to be sent to you. Okay. And the today quiz is the case of an 89-year-old male presented with hotness, and this is his MRI imaging. Okay, and my question are which part is more likely to be the center of the laryngeal site and give the possible primary tumor state associated to the TNM staging system. You can answer this question by scanning the given QR code, and I will give you 1 minute to answer this.
Can you show us again the images?
Okay.
Thank you.
Okay, the last 10 seconds. Then thumbs up. So the correct answer is A, glotis and T3. And this patient underwent total laryngectomy, and the pathological diagnosis was squamous cell carcinoma. And the definition again of T3 of glotis carcinoma according to TNM staging system indicate that the tumor is limited to the larynx and vocal cord fixation and or invasion of paraglottis space and or inner cortex of thyroid cartilage. Okay. Then today I hope you guys enjoy and gain more knowledge about the imaging of laryngeal and hypopharyngeal cancer. And before we close the session, I'd like you to do the evaluation form by scanning this QR code. And I'd like to inform you that only those who complete the evaluation form will receive the certificate. Okay. And we will get back again on the 4th February 2024 with the lecture title Cellular and Paracellular Tumors by our talent associate, Assistant Professor Carlos Zamora from the University of North Carolina School of Medicine with a moderator associate Professor Dajams from Mongolia, Japan Hospital, Mongolian National University of Medical Sciences. Okay. And I guess that will be all for today. Thank you everyone for joining. And thank you again, Professor Bandit, for your wonderful lecture.
Oh, thank you. Yeah, you are welcome. Bye-bye.
Have a good time, everyone.